Interesting session, I think, on refractive surgery. To start with, I think our friend Dr. Shilpa Kotkani, she'll be talking about interesting cases in refractive surgery. Once again, I think we tried our level best actually to get this light off, but uh, yeah, I complained to all the organizing committee also, sir, but they are helpless. Yeah, yeah. Please start, Shilpa.
Thank you so much, sir. And first of all, I thank the organizers for having given me this opportunity. Interesting cases in refractive surgery. Well, there are many, but to cover up in 7 minutes, I have just a few. This is a patient with a minus 6.5 with a minus 1.5 at 180 degrees in the right eye, with a minus 8, minus 1 at 10 degrees in the left eye. She was 24 years old. The pachymetry was 520. Topography was normal. The right eye, with that kind of power, the ablation would be around 130 microns. The residual stromal thickness would be about 320 microns. But we decided to do an ICL because doing a PRK with such high refractive errors not suitable, and even to do uh, femtolasic or a microkeratome LASIK would be going a little too deep, and that's why we decided to do an ICL. So if you can see the chart here, hopefully you can see it. uh, the anterior chamber depth is good. The white to white was 12.5, and that seemed a little odd to me because her cornea was not looking so big. So the lens that we had to put in was a 13.7 lens, which also seemed a little on the higher side. But then I went and did a white to white again and again to check, and I usually use the digital calipers. So I did that, but 2 3 times checked it, and it came 12.5 again and again, and this was what it was. Post surgery, as you can see on the slit lamp, the anterior chamber is really very shallow, and there is a high vault like this. And this is something that I did not, well, I thought that there's something wrong out here, but I still went ahead and did the procedure, and this is what I got. And since it was a -1 cylinder, I even considered rotating the ICL vertically to be able to get a little more anterior chamber depth. That is what we usually do. And then the left eye, of course, we can't go ahead with the left eye with this kind of because both showed 12.5 white to white, the same kind of readings out here as you can see, and 13.7. Of course, I did not want to use a 13.7. I went in again and I rechecked the white to white and confirmed with the digital calipers again it was 12.5. Then I took a calipers, the regular calipers that we have, and we use the ruler to see how much it is, just to confirm it, and it was 12 So I reduced the ICL size to 13.2, and this was what the AC anterior chamber depth was. Definitely, as you can see here, the comparison between the two ASOCTs, the left eye had much lower vaults, and the IOPs also were good. So this is what we see, um, the right and the left if you compare. So the message here is, what I realized after doing this surgery was my digital calipers was somewhere not calibrated. There was something wrong with it, and I had to stop using it, and I went in and got a new one. And I always, after that, recheck with the calipers. And of course, if you have the obs cam, then that is another method of checking the white to white. Now, this is another case with a refraction like this. 29-year-old girl, married, no kids, will have kids in the future. This is the pentacam picture here with a pachymetry of about 500, and you can see that the topography is looking good out here with the bad score being like this. As you can see, there is this yellow here which is saying that there could be, like, it's a borderline kind of a case probably, but we don't know. um, this is the left eye, again pachymetry being the same. As you can see, the map looks okay. Again, the bad being like this, where it is slightly on the lower side. So what I decided was, she was a young girl, could get pregnant, have kids later. So I was in fact telling her, you finish all your family commitments and then maybe we could go and do it. But she was very, very keen to do it. But still, we waited for 1 whole year, compared the topographies, and saw that there was no change whatsoever. But then went ahead and did a PRK and not a microkeratome or a femtolase. Now, this is a very, very interesting case that we had. 53-year-old male with a history of LASIK done 20 years back somewhere, where no details were available about any kind of topographies or anything. The right eye vision was 636, left eye was 618. Both eyes had an NS2 cataract. So the plan was, now you would ask me, why did you go for this toric panoptics? Well, the patient was very, very keen on having good near vision also. So we did all the necessary things. Right eye was operated, patient was very happy. We planned the left eye, and this is what we got. 636, not accepting, no improvement whatsoever. And we did the topography and we found the right eye being okay. As you can see, it was more or less good, but the left eye was showing some kind of a problem. As you can see here, steepening and, okay, can I take 1 minute more? Okay. So a little steepening and a little flattening out here, so this doesn't look very good. And we were wondering what it could be. We did the aberrometry, and this is what you can see, the right eye and the left eye in comparison. And so higher order aberrations, comas, all being there, a little bit of spherical aberration also. So we decided to do a corneal wavefront guided surface ablation for this patient. And after that, see the map. This is what it was pre uh, uh, wavefront guided and post. And you can see that it was, the cylinder has come down drastically. The higher order aberrations have come down, but 2 weeks later, there was a surprise. The patient had 4 by 60 vision, dropped from 636 to 460, and a -5 spherical error. So what do we do? Because what has happened is, if you can see the K readings, 39, 37 has gone to 41. And this is what caused the spherical error to come in. And we decided to go in and do, because the cornea was 520 microns, we did a trans PRK with a mitomycin C, which was kept for 1 minute because there were multiple procedures done on this patient. And the patient got 6/9 part vision with N8 unaided, which finally, even 6 months later, 1 year later now, patient is quite happy with the vision that he's got. So this was another case that we had. Thank you so much.
Dr. Cooker, sir, any comments?
Yeah. Do we have time for discussions, or we can do it at the end?
In the end, discussion is better, sir.
Yeah, we do
End.
it at the end. So just don't run away. I'll add on to the audience also. So can we call upon the second speaker
The
now?
second speaker, Dr. Mukesh Paryani, he'll be talking about the phakic challenges. The third speaker, Reshma, is here. Reshma Javeri.
Yeah,
Then I will.
that's here. We have taken that.
You came late, we already done the work.
I finished instruction.
That's okay, fine.
This is the reason. You're not here. You discuss with me later on before you go. There's lots of things you could have done better. I'll talk to you later. उधर से copy लेते हैं.
इसके बाद में आपका है रेशमा
You got two. Two. I'll talk press beyond first. Whichever. Sir, you got a record. Do whatever you want.
Good evening, everyone. The topic that I will be speaking on the challenges that we face in phakic IOL surgeries. Uh, to start with, I have no financial interest, but these are the phakic IOLs that I do. I do a lot of care groups IOL, the star ICL, and less of the ICRL phakic and the upper IRL that I have started very recently. Uh, the challenges that we face can be divided into the four challenges that we normally see: the calculation challenges, the sizing challenges, the surgical challenges. That's I'm going to show some of the videos regarding the same, and the post-operative challenges that we face, even if the surgery has been uneventful. The calculation challenges per se starts right from the patients who are high myopes. They have a lot of pseudomyopia, accommodation spasm. So that's where we always tell all the workups has to be completely done under cycloplegic refraction, because even if the patient is having around, we have seen 3 to 4 diopters of pseudomyopia, and that can land them into a post-operative refractive surprise. The challenges that we face most is in the patients with the keratoconus or post-LASIK ectasias, because the refraction itself is the stringent task in them. They will have varying of refractions, and calculating having a good refraction in them is the major task in them. And obviously, when I talk about the SIAs in the phakic IOLs, that's fairly less in normal corneas. We hardly consider SIAs. It's been lot research in the past in 2012-13, but the SIAs in ectatic cornea will be fairly more as compared to the SIA that we see in these ectatic corneas. For example, if I'm planning in a keratoconus patient, a phakic IOL, the first and the foremost thing that I would require is a long stability of a cone following a C3R. Unless you have a good full documentation of stability in a cone, perhaps straightforward, it's a no case for a phakic IOL. Once the stability is achieved, the outcomes are fairly good. One more challenge that we face here is the K values are 58, 61, 64. These will land up and give you a ACD which is falsely very high. Always deduct some amount of anterior chamber depth and then send it for calculation. So suppose if your ACD is showing 3.6, that's a false ACD. Perhaps you send for the calculation as per 3.3 millimeter ACD, so that you get a lens which is having a fairly normal vault as compared to what otherwise you would land up with. And usually we land up, what's a normal wall that we target is usually around 400 to 800 microns, although it's 250 to 750 is what is normally we used to target earlier. But now with the lens rise and the other factors coming into play, a target which I normally keep is around 400 to 500 microns vault. Sizing challenges, we have lot of challenges while we are calculating the white to white measurements, as it was elaborated by the previous speaker as well. A digital caliper, a well calibrated digital caliper is the must. And also, not only that, whenever you're ordering a digital caliper, it has to be a mini digital caliper and not just a digital caliper, because mini digital caliper are very easy to handle. They are just 3 inches or 4 inches. You get it easily on Amazon and will give you very easy thing. One more thing that you can do is have the Shermer strip there. You can calculate it using the Shermer strip as well. And ACD measurements, as I told, in keratoconus, you have to be very particular. S2S measurements using UBM in patients where you get a lot of variability. Like if you get a different white to white from the optical biometer or the topographer, and your manual digital caliper is absolutely different, it's always better to go for the sulcus to sulcus measurements in those. The vault challenges, as I said, you have a normal vault, a 758. I would consider it absolutely normal. In fact, better vault. And the smaller vaults like 119 would be less, and more than 1000 would be something which is abnormal vaults. A white to white measurement is the most important thing, and I always emphasize it has to be done under the microscope. with the patient in supine position, take a speculum. It has to be done by two observers. Now that's very important. It has to be done by two different observers. Take three readings, make it to the caliper to the 0 point again, press 0 so that it's calibrated, and that's how you take the accurate white to white, and then adjust the white to white as given by different devices. We had done recently around 165 eyes of the patients, where we found that the white to white given by the pentacam was not statistically different from what we were getting by using a digital caliper, and that gave us the vault, post operative vault, between 400 to 800 range. So two devices, manual, digital, white to white by two observers, always under microscope, and STS whenever in some cases. If the vault is high, if the vault is more than 1000 microns, perhaps rotation of the lens in the vertical position, if not toric, can be done. Or perhaps, when in doubt, please exchange the lens then and there itself rather than landing up into complication. If the vault is too low, less than 100 microns, perhaps a straightforward case, you have to explant and exchange it. If around 150, 200 or a little more, observe very closely, because the central vault is different than the mid peripheral vault. The central vault may be around 100, 200. The mid periphery may be little lesser, particularly in high myopes and those with a lot of toricity in them. So always see the mid peripheral vault more than the central vault, because central vault nowadays comes with an aqua port or the central hole, so the oxygenation will keep on happening. The mid periphery is the area that's going to affect the most. The ACD measurements can be done from any of the devices, and almost all of them are fairly equal. In hyperopic patients, keep an ACD of at least 3.2. It said 3, but at least you should have 3.2. More than that would be a very ideal case of doing a hyperopia. I have limited experience in doing hyperopic, but whatever we have done as of now, holding well, and you require a PI. uh, I will just show two or three small surgical challenges that I have faced. One is that we always nowadays go with a 2.8 incision. Sometimes the difficulty in the injecting the lens. In all these cases, it is very important. Slightly enlarge the incision so that it goes very easily. Particularly the star ICL, please make an incision up to 3 millimeter so that the injection becomes absolutely smooth and more predictable. Now, what happens in some cases is the inverted insertion of the lens. This was used as a piggyback, and the lens goes in very nicely, but suddenly the haptic gets stuck between the cartridge and the plunger, and that's where you kind of land up into an inverted phakic IOL. Now, for this, what we had changed over the past is to start having a second instrument. Now, this is last two videos, they are very important here. Is whenever I am putting an phakic IOL, just give me 1 minute, these are very important. Huh? So I put a guard from the Vukix manipulator goes in first. The Vukix manipulator acts as a guard there, and I inject the phakic IOL. Now, suppose in case it is not opening in the way I want to, my first target is to make sure it is well away from the endothelium. I hold it, the phakic IOL there itself, simply give the injector to my assistant, take the second instrument. I usually keep two Vukix manipulator, keep the lens very much away from the endothelium, and simply rotate in the way you want to rotate it. The lens is very much away from the endothelium. I have another video which exactly shows how much away it is from the endothelium. I want everyone to just focus on the bubble that's at 7 o'clock position. Now, as we are injecting the lens, perhaps going a little faster than I would normally do, and it's not opening the way I want to, perhaps just about to flip open. I am just keeping the using the Vukix manipulator lens there itself. The bubble comes into play here. The bubble will be showing us the different gap between the endothelium and the lens again. This is where my second instrument, Vukix manipulator, will come again, and that space is very well maintained and it opens in the way I want to. So hereby we can prevent the flip by still staying away from the endothelium.
Can you please
Post-operative.
sum up?
Yes, done. I will sum up here. This is the last video which I would say, and then perhaps I will close. It's a 80-second video. Hyperopic IPC, hyperopic phakic IOL. It would be perhaps seen here. It had an optic capture, and we are planning to take the patient to the OT for just repositioning the lens. But I told my fellow to just go up and take a picture of it. She started constricting the pupil with the high beam light, and we were absolutely fortunate that the optic capture was completely reversed just by using this particular light. So you will see that here it goes, and the patient still comes for follow up. No need, we didn't have to do anything for this particular optic capture. Thank you so much for your kind attention.
Thank you. Thank you very much. Now we invite Dr. Kudlu for his talk on the management of intraoperative
That I'll be
complications.
talking in the end.
That will be later.
Last talk I'll talk before only.
Okay. Yeah. You can
You can have both the
both
talks back to back.
back to, you can finish
No,
both of them.
because Smile regular talk, let Sonu talks, then I talk on complication.
Okay.
Makes
All right.
sense, sir.
Okay.
That is the reason I
okay.
did like
Okay. Okay. Fine.
Thank you, sir, for the opportunity. In fact, I'll be talking about this talk since quite long period. This is my financial disclosure. I am consultant for Carl Zeiss India. So, what exactly is the presbyopia? It's a physiological progressive loss of effect accommodation affecting individual in their middle age, regardless of underlying refractive error, causing difficulty in sharply focusing for near vision. So, of course, how good presbyopic treatment is going to affect your practice. This is very, very important because most of the uh, patients are now presbyopes, especially parents and relatives of LASIK patient who also wants to get rid of the glasses. And even nowadays, a lot of patients with the emmetropic presbyopes also coming to us and asking for to get rid of their glasses. So the principles to correct presbyopia, one is you can do monovision, you can do multifocality presbyopic treatment, or you can think about increased depth of focus, what we used to do in camera inlays, or you can opt for combined approaches. This is the surgical treatment for presbyopia. You can tackle sclera by putting scleral implant or laser rays procedure. Cornea, you can do presbyon, intracore, even camera inlays. You can, lot of my friends are also doing presbyopic contact lens practice. In the IOLs, I think you got a gadgets of IOLs. More so popular one is EDOF and trifocals. So I'll not be talking. This is a principle about the presbyon, basically monovision principle, depth of field to reduce anisometropia, spherical aberration control, vertex centration of spherical aberration, multifocality, neural subvision, blur adaptation, and neural suppression. What exactly we do in presbyon? We make the dominant eye emmetropic and make the non-dominant eye myopic by 1.5 adapters, with the creating a spherical aberration in both the cornea. By doing that, we will have a something called blend zone, where the image from the dominant and the non-dominant eye meets up and binocularity retains. So basically this treatment you have to do the bilateral treatment. So coming to the preoperative evaluation, who can undergo presbyon? Any patient in myopia with a large number of power, I have done up to 8.5 adapter depending upon the Paki value. Hypermetropic up to 5 adapters I have done. Even I have done more than 200 patients with emmetropic, and patient with astigmatism up to 4 adapters you do it. But make sure that patient don't have the cataract. So refraction, all my patients I do a cycloplegic refraction. Then I myself check for the dominant eye testing. I'll come back to the later on. So history is very, very important. See, all my presbyopic laser refractive surgery, my chair time is 45 minutes. I never give to my counselor. I spend with the patient. I ask all the history, what medication they're on, what is their expectation. Then I really decide whether this patient is suitable for presbyopic laser surgery or not. So coming to the uh, pre-op examination, you need to look at the pupil reaction, size of the pupil, see for both corrected and uncorrected distal visual acuity. Then after doing, I think I am not talking about all refractive patient. I think you have to do a proper dry eye workup and do a very good indirect ophthalmoscopy. Make sure that retina is normal. So very important refraction. See, in spite of lot of optometrists working with me, this part I myself do. So once I do the refraction, both the eye, make sure that it is duochrome balanced. Once it is duochrome balanced, Then I do how to know the dominant eye. So to know the dominant eye, make a small aperture in the both the hand together. Tell him to see for the distant letter. Then tell him to get those both the hand near to his eye. Whatever the dominant eye the patient is going to get. So you can cross check with by closing each eye. Then you know that which exactly is his dominant eye. Once you know that which is his dominant eye, then the next step is do the micromonovision testing. So this is the refraction of the patient. For this patient, left eye is the non-dominant eye. I have put a plus 1.5 diopter. So with the same correction on, I told him to read the near vision. If you start reading N5, then with the same correction on, I'll tell the patient to see for distance later. If you start reading like with the same correction on for distance 6 and near vision N5, these are the patient do really well. So these are the different test also know the dominance eye. You can do something called pointing test, you can do shooting stimulation, or you can do a finder hole test also. All gives the exact similar results. So most of the patient he'll have dominant eye, we do it correct it for distance, non-dominant eye for near vision. But some patient will have a no clear dominant, they'll have an alternate dominance. These are the patient, they are very tricky when you are post them for a presbyon. So you have to repeat this test, and the documentation is very very important. So basically once you do that, I think pentacam topography, I do have got atlas with the Visante OCT from Zeiss. I think that been helping me for very long period, which gives accurate result even post a float. I will compare with the pentacam also. Once you do with this, then next is the software. This is very very important. So everything will be decided by the software only, you need not have to enter. So this is the one test I do for every patient, that is about the eye trace. Normally in eye trace I look at the dysfunction lens index. That means if the DLI is lesser, then this patient is already having earlier cataract, those patient I will not do the presbyon surgery. Then you can do the VASCA also, and enter this VASCA report within the CRS master. This is about the procedure, the typical femto, the Visumax. I got Visumax 500. The femto with the Visumax 500 or 800, the one of the best femto machine available in the market. So once the femto flap done, I think the patient has moved under the excimer MEL 80. Can be done even with the MEL 90 also. Once the flap done, then lift the flap. The treatment is similar how you do the any of the LASIK treatment. The procedure is similar. The treatment will plan done by the machine. Once the treatment done, flap is reposited back. These are our results. I think I'll just take a half a minute, sir. Results: the 500 patients, in that 270 patient myopia, 130 patient hypermetropia, and 100 emmetropic patients. What you can see in the result, none of the eyes lost more than half a Snellen line of vision when compared to the preoperative corrected visual acuity. That means whatever the patient had vision before, they retained. So basically all the patient even retain functional stereo acuity, no loss of contrast sensitivity. This is about the recovery phase, the physical adaptation phase and neural adaptation phase. So normally patient take within some of the patient even adapt within a day, maximum some of the patient even took up to 4 months time. So basically this treatment is not depend upon the pupil size. You can do a high refractory error. All my patients had a very good intermediate and near vision, adapted is more than 97%. So in the end, which is the best presbyopic option? If you compare all the option in the market like multifocal lens, corneal lens, presbyvax, supracore, I think definitely presbyon will have a edge over all this treatment. Probably the best and the safest presbyopic treatment available till date. Once again, I thank Zeiss also for this opportunity. I thank scientific committee for this opportunity. Thank you, Ananda.
Dr. Rashmi.
Reshma is not there.
Oh, sorry, Reshma. Dr. Reshma. Anusha?
Anusha, right?
Yeah.
Anusha Jwani.
Dr. Anusha Jwani, please.
till the time the presentation is set up, can we take one comment each from the first 3 talks that were done?
Yeah.
So phakic IOLs versus LASIK. Now, even in cases in which LASIK is possible to do, more and more surgeons are preferring phakic IOL because it has become more safe and reproducible. So, is that the message that we want to give now to the youngsters?
Of course, I think it's a reversible thing and you don't have a loss of contrast. So whatever surgery you do on the surface, be it a PRK, LASIK or SMILE, you always have an interface, even if you can't see it. The problem is stromas are going vertical and you cut it off. You can't match it again. Never ever anything is possible. So even if you give vision 6.5, it's not the same vision which should be. So ICL is the way to go in this one. Yeah, so I think she's ready.
Anusha.
Yes, Dr. Anusha.
I thank AIOS for giving me this opportunity. So I'm Dr. Anusha Ajwani, Director and Consultant at Ajwani Eye Hospital, Bhopal, and I'll be speaking about post-LASIK epithelial ingrowth, its causes, clinical features, prevention, and management. So epithelial ingrowth is basically the presence of epithelium in an area where it does not belong, and after LASIK, it occurs in the interface between the flap and the stromal bed of the patient's cornea. Its incidence following primary LASIK is very low, estimated between 0 to 3.9%. However, it increases when the flap is lifted for retreatment or enhancement, ranging from 1.7% to 23.3%. So the corneal epithelial cells can be introduced into the interface in 2 ways. Firstly, during the microkeratome pass or other parts of the procedure, and secondly, due to loss of contact inhibition and the presence of a pathway to the interface. Coming to the risk factors of epithelial ingrowth following LASIK, these can be classified as non-modifiable and modifiable risk factors. So the non-modifiable risk factors include patient factors such as corneal epithelial basement membrane dystrophy, history of recurrent corneal erosions, type 1 diabetes, older age group. Hyperopic LASIK is at a higher risk as compared to myopic LASIK. Apart from that, microkeratome assisted LASIK is at a higher risk as compared to femtosecond LASIK. Prolonged manipulation of the flap and excessive instrumentation at the interface, partial flaps, flap misalignment or dislocation. Surgical technique used can also can be a risk factor, and direct flap lift with forceps is at a higher risk as compared to cleaving with spatula before lifting, corneal epithelial injury, buttonholes, and spillover of ablation at the bed margin. So based on the location, clinical features, and severity, PLEI can be classified into 4 grades using the Provost-Machart classification. And this classification serves as a useful aid for consistent and standardized grading and provides guidance on the treatment strategies. So in this grade 1, there is a thin growth with a well-delineated white line along the advancing edge with no flap change. The location is 2 mm within the flap edge and no treatment is required. In grade 2, there is a thicker growth, no demarcation line along the nest. There can be presence of rolled or gray flap edge with no melt. It is located 2 mm within the flap edge and no urgent treatment is needed. In grade 3, there is pronounced growth. There can be opaque ingrowth with geographic areas of necrosis with no demarcation line, and it is located more than 2 mm from the flap edge and treatment is needed. In grade 4, there is aggressive growth which can result in flap melt, threatening or affecting the visual axis and requires urgent treatment. So coming to the prevention, to avoid epithelial ingrowth, patient selection is very important. Patients with the stated risk factors may achieve better results with PRK than with LASIK, thus avoiding the possibility of epithelial ingrowth. We need to avoid prolonged manipulation of the flap, clear an epithelium, tags or debris from the stromal bed prior to flap repositioning, apply BCL when epithelial defects are observed, and it's always a good idea to use new blades with minimal and careful use of topical anesthesia. Coming to the management, for mild and non-progressive epithelial ingrowth, that is grade 1, no treatment is required. We need to carefully observe the patients to ensure that the growth is not progressing. Intervention is needed only when ingrowth appears to be progressing, affecting the visual acuity or causing flap melt. So the most common treatment strategy for PLEI is mechanical debridement of epithelial ingrowth from the flap stromal interface and from the inner side of the flap, followed by careful repositioning of the flap and avoidance of any intraoperative or postoperative epithelial trauma. It is a good idea to resect the epithelium from around the flap bed. Use balance salt solution to irrigate the interface, the flap, and the stromal bed to ensure removal of all the epithelial cells. Then tightly replace the flap, followed by placing a BCL. Flap suturing, fibrin glue, and ocular hydrogen sealant at the flap edge have been proposed to facilitate secured flap adhesion. Apart from that, in refractory cases, adjunctive therapies such as ethanol mitomycin C can be used to help eradicate PLEI. Amniotic membrane grafting may be used in cases associated with flap injury or melting. And in severe ingrowth with melting and folds, it is better to remove the flap and allow for healing. Use of ND-YAG laser has also been reported as a novel technique for treating PLEI. ND-YAG laser produces short individual pulses of focused infrared light, 30 to 40 pulses of low energy beam focus slightly posterior with respect to the epithelial ingrowth starting in the center. The power is adjusted to the minimal amount to form bubbles. At the margin of each bubble, new spots of laser are shot until the entire area of epithelial ingrowth is treated, sufficient enough for blocking progression and to decrease the size of ingrowth. So in image A, here we see that there is epithelial ingrowth at the interface. In image B, that is at 1 month after first session of ND-YAG laser treatment, epithelial ingrowth has well-defined borders. In image C, it is at 1 month after second session of YAG laser. Epithelial ingrowth has further decreased in size and density. And image D, that is 2 years later of ND-YAG laser, demonstrates minimal scarring in the interface at the site of previous ingrowth. However, ND-YAG laser itself has certain complications and can result in localized flap melt and flap surface breakthrough, with the creation of new channel at the flap edge resulting in new areas of epithelial ingrowth. So the recurrence rate following treatment depends on the treatment strategy, and follow-up duration ranged between 0 to 44% due to improper adhesion of flap. Mechanical debridement of both the interface and inner aspect of the flap followed by application of fibrin glue appears to have the lowest recurrence rate of PLEI as compared to other treatment modalities. So to conclude, with the continuing rise of LASIK procedures, it is important for ophthalmologists to become competent in recognizing and managing the post-LASIK complications, including PLEI. Understanding of risk factors helps to reduce the incidence and also enables better patient counseling. And when appropriately managed, good visual prognosis is usually achieved. Thank you so much.
Thank you very much. Dr. Sonu Goel, can you start? He will be talking on unleashing the new VisuMax, setting the new benchmark for the LVC practice.
So very good afternoon, and I think to take can you switch on the light? Yeah.
No, you cannot do it, sir.
Yeah, you can start, Sonu.
So thank you, Dr. Khoker, and thank you, Scientific Committee, for having me a part of this program, unleashing the new VisuMax 800. So I think we had a lot of discussions on ICLs, LASIKs, PRKs, ingrowths, and I think gone are those days. Why don't we talk of lenticules? And I think something which I really amazed, 400i, 6 months, and this works amazing. So what is amazing about this is that it's right on target, it's faster, it's robotic, and it speaks. So how does this go? Let me see. So we all know the key steps in smile surgery. So first is this. This step, it takes around, if you see 10 seconds, this is 2 seconds. So I'm creating the base of the lenticule, then I'm creating the side cut, then I'm doing a cap, and then a cap side cut. So 10 seconds, 2 seconds, 12 seconds, and almost around 3 seconds. So that is what compounds to 28 seconds when I'm talking on Visumax 500 or a creation of a lenticule on any other platform which is not on the Zeiss platform. So Visumax 800 different from 500 because the frequency from 500 goes up to almost 2 megahertz or a 2000 hertz system. Now what does this gives me? It gives me a very fast system. It reduces actually the laser time and creates a lenticule which is usually less than 10 seconds, a flap which is less than 5 seconds. And this, what does this shorter suction time actually translates? So it adds a peace of mind both for the surgeon and both for the patient. So it reduces the stress time for the patient, translates into lesser dry eye, lesser loss of the epithelial cells, and lesser suction loss. So what I want to emphasize is translation from 28 seconds to 8 seconds gives me that suction loss which cannot happen. 400 eyes in these 6 months, I didn't have a single patient for a suction loss. So the second most important is the energy transitions, which creates the tissue separation. The energy levels from 4.5 to 3 microns, the spot spacing, and the spot spacing for the side cut to 1.5 boils down to a very easy tissue separation. So just watch this here. Suction loss, we all know, in the various multi-center studies, 50% of the times usually occurs in the first maybe 13 seconds. And this 30 second before the side cut, I think for most of the Visumax 500 users would see, whenever you have a suction loss, your face goes back on the charts, which says whether you can redock and restart the treatment, or you actually need to convert to a flap, or you take a new pack and start again. So 12 seconds means you didn't have a lenticule side cut, and you actually cannot proceed to a lenticule and you convert to a flap. Now, this is those situations where Visumax 800 outscores the 500 because the treatment time is 8 seconds. So 8 seconds means when most of the part is over. So this is what has really helped us in our initial 400 patients, not even a single patient that we had a suction loss, because the process is just a blink of the eye. The second important, with the reduction in the spot spacing, has actually translated into what we call as the ease of the lenticule separation. This beautiful paper from the RP Center, and Dr. Coker is a witness to this. I would really compliment him for the excellent work that they're doing on refractive platforms. So basically the paper speaks on that the difficult lenticule dissection and extraction is the most surgically challenging part of the smile surgery. Now, when you have a very smooth lenticule dissection, I don't think there is any chance of we having complications related to lenticule dissection and lenticule separation. One great feature with this equipment is the centration. Now, we all know that whenever you have a decentration more than 0.3, it basically boils down to induction of aberrations like coma and spherical aberrations, and that too, it is more magnified when you are dealing actually with more of astigmatism. So if you are just treating a plano, it could not be so much aggravated, but if you are treating a plano with a cylinder, you have a decentration, it actually leads to more of induction of these aberrations. So the center aligned system with this 800, it is what is very important. So you have your ILMaster 700, which is actually speaking to the Visumax 800 on a forum platform. So the patient data is captured on the Atlas, on the ILMaster 700, and then you take the patient on the Visumax 800. So the angle kappa, which the XY centration, which you have taken from the Atlas, would be directly taken on this system, and this actually takes care of the centration. So what I want you to actually look into is this. So this blue is less than 0.2 millimeter of decentration. Anything more than between 0.2 to 0.4 would be something yellow here, and anything beyond 0.4 would be a grossly decentered. So the target is just to center here so that there are no questions of angle kappa. So you're treating right on the visual axis. So that is what boils down to Vision 2020 Day 1. So I think this is one beautiful, innovative workplay that they have got. So just a quick video which I want to you to experience how fast this equipment and what is the ease of workflow with this Visumax 800. So the patient properly paint draped and BSS properly dried, and this is how you see the arms working. So this is the operating microscope, and it's again an amazing tool which has both the slit lamp adapters And so this goes up, and this is the laser microscope which comes down. So you have here the this is the joystick which works here, and once you rotate, this is the interface. This is the laser delivery system which comes down. So you need to put the disposable suction attachment here, and this is directly attached here, where you have a magnetic attachment and it directly glows. So now this is the graphic interface display, and this is the centration that I'm talking about. Just watch carefully. There is a ring in the center, and you actually need to get this yellow inside the ring. So the moment it turns blue, that means you are right within 0.2 millimeters or less than 0.2 millimeters. 80% docking is the time when I apply the suction here. Just watch. It is just 8 seconds. So this is the lenticule, the side cut, the cap cut, and this is the cap side cut, and the time is 8 seconds. So by the time you start talking to the patient, the procedure is actually complete. So that's the beauty with the 2000 hertz system. And the second thing is the ease of dissection. Watch carefully. So this is, I open up the side cut here. I just go up, separate, go down, separate the base of the lenticule, and this is my dissector. I just go in straight. I'll just take a minute more, sir. I just go left, I go right, and that's the cap. I go underneath the lenticule, go left, put a small stump there, and go right there. Just watch the ease of dissection. There is no pressure that I'm exerting. Remove this, and this is what Dr. Gaurav Luthra, my dear friend, has taught us, the hydro expression, and the procedure is quite over. And this is what translates on day 1, the slit lamp picture that I'll show you here, and that's the patient 2020 day 1. There is hardly any evidence that you can see the patient has undergone any refractive surgery. So that's the beauty of this system that we have been experiencing for the last 6 months. A quick word for the third key feature with this equipment is the cyclotorsion alignment. And we all know that cyclotorsion, various studies have shown, could be somewhere between 3.3 to 4 degrees. And this actually takes care of cyclotorsion. Now, how does it take care? This would, once you have the access to the IL Master 700, both the equipments would be talking. I want you to have a look here. I have marked the 0180 here on the slit lamp. Now I'm trying to dock the patient here. And once I've docked, this is the axis. So with the joystick, once the docking is done, I can rotate the joystick to the desired axis, maybe right or left, clockwise or anti-clockwise, bang on the target, so that it coincides with the 0180 degree marking, and you can achieve an excellent compensation of the cyclotorsion with this equipment. So all in all, a few of our results. What I wanted to emphasize is the reduction of the HOA. So initial 300 patients that we have done actually showed there was a significant decrease in the horizontal coma and the spherical aberrations. And this actually what translates you to 2020 day 1. It's quite predictable, very safe. It's comfortable to the patient, and the quality of the vision is excellent. The workflow has been excellent, and it basically translates into less surgical and OPD man hours. So thank you so very much.
Thank you, Dr. Sonu. It was excellent talk, and in fact, probably the best machine available in the world in terms of the time and also the least complication. And even what I'm doing, see, the dissection is so easy. I could able to see. Even while doing the dissection itself, the lenticule may come along with the dissector. That smooth dissection you could able to see. Very good results. I think if they start, I think you'll have hypermetropic treatment in the coming days. I think even soon, I think Zeiss will also have a presbyopic treatment in this platform. It's going to be the great machine for most of the refractive surgery treatment.
So I think one platform for all refractive needs. Thank you very much.
Yeah.
Complications you want to take up?
No, sir. Complication. One more complication is there. I think someone. You can talk. Payal.
Anand? After this?
Yes, sir.
Next, Dr. Sudarshan Kukar sir will talk on. Next, you talk, sir. Mel 90.
Anand is there.
Last is fake kick.
Anand is there.
Yeah. Anant, your presentation is ready.
So before I start, I thank AIOS for giving me this opportunity to present. So I would be talking about tough situations in Smile and how we aced them. So life is like a mirror, smile, and it smiles back at you. So now we know a lot of things about this refractive lenticule extraction Smile. This is the latest technology. It is purely femtosecond laser based. There is no flap created. A very small corneal incision of 2 to 6 mm is required. A better corneal integrity because of no flap and almost very minimal to no dry eyes. So just before starting with the complications, just brush up with the steps of Smile. So first, topical anesthesia, sterilization and draping. Then the eye centration and fixation with the blinking green light of VisuMax 500, what we have in our center. Then docking with a curved surface suction fixation cone. Then the femtosecond laser firing starts. As sir also said, first it is the lenticule deep cut. It is centripetal from out to in. Then the lenticule side cut. Then the cap cut, that is superficial, that is centrifugal from in to out. And finally the entry pocket, that is superior or superiotemporal based on the ease of the surgeon. Then the suction is released and the eye is undocked. Then the manual dissection of the lenticule is done with the Duckworth and Kent Smile double-ended dissector with a spoon chip. First the cap dissection is done and then the lenticule. Finally lenticule extraction with Smile lenticule removal forceps. So now let's see a small video. So the lenticule cut, side cut, now the cap cut and the entry wound. Now first the cap dissection is opened up. Then the lenticule is opened up. Now the cap dissection is done with the spoon tipped end of the Duckworth Kent. Now the lenticule dissection just beneath.
Did you use 800? It's so fast.
No,
Is
500. The video is fast forwarded to.
I thought it's faster than 800.
No.
It must have got 1000.
Just to fit into the 7 minutes time. So, yeah, okay. So now, what intraoperative complications we come through? So literature says some of these complications like suction loss, altered or incomplete opaque bubble formation, dry spots, decentration of ablation, incision tear, complications during lenticule dissection, and an incomplete lenticule extraction. So let's see one by one. So this is the most common complication almost all of us face. This is suction loss during docking. Just I was discussing due to the 28-second time of the laser firing in VisuMax 500. So literature says about 4% of cases undergo suction loss and majority have suction loss during creation of the anterior lenticular surface. So what kind of patients we face suction loss? The most common of it is Bell's phenomena, a sudden upgaze of eye turn, then anxiety, pain, tears in the conjunctival sac, pseudosuction, improper docking, low docking pressure system, and a new surgeon who is doing Smile for the first or second time. So how to ace it? So as per the literature, if suction loss occurs before laser initiation or during creation of less than 10% of the posterior lenticule surface, we continue the procedure with the same parameters. If the suction loss occurs after creation of more than 10% of the posterior lenticule surface, the procedure is converted into a femtosecond or a flap procedure. Now if it occurs during creation of the lenticular side cut, the same procedure is done after decreasing the lenticule diameter by 0.4 mm. And if it is after the creation of anterior cap surface or incision, it is done with the same parameters. And if after the lenticule side cut, retreatment in the same settings could result in hyperopic correction. So that time the procedure is aborted and a reprocedure is planned later. So I'll show you one case with suction loss, again a fast forward video. So in this case, the suction loss was just after the cap cut. Now there is a suction loss. Now redocking is done and the entry wound is prepared and rest of the procedure is carried out normally and whole lenticule was extracted out. So when the patient presented next day post-op, the visual acuity was 6/9 partial in that eye, which gradually improved to 6/6 and 6 in the coming month. So two more similar cases. The first case, suction loss was during the posterior lenticule cut. We can see around 50% of the procedure was completed. The procedure was aborted and planned for femtolasic with a decreased flap thickness of 90 micron. In the second case, the suction loss was there as soon as the laser firing started. So the patient was counseled, calmed down, redocking was done, and the procedure was completed with the same parameters. Now the second complication which we faced was dry spots during laser firing. So occurrence of multiple black islands of incomplete photo disruption after femtosecond laser. So when the docking is placed, generally the interface should be clean and devoid of any debris, water, meibomian or conjunctival secretion. Otherwise, the laser firing is incomplete and the dry spot create, and dissection of lenticule is difficult due to microadhesions between the lenticule and the corneal stroma. So this is one video. So there was a dry spot. The laser did not penetrate. And there was a difficult dissection at that point of time in that particular area. The dissection had to be forcefully done, taking care that cap perforation does not occur or the incomplete lenticule is not taken out. But at the end of the surgery, complete lenticule was taken out. The lenticule is taken out, and next is the visual acuity is 6/9 and the ASOCT. Now another complication which we faced is incision tear. See, this is the eye where the incision tear took place. It is generally encountered during early learning curve due to increased manipulation during dissection, smaller incision site, strong Bell's phenomena, and sudden head movement of the patient while the instrument is still in the interface. So we can treat it with bandage contact lens and copious amount of lubricants. And if there are irregular tears with excessive dissection, it can disrupt the epithelial cells at the site of the tear and may be a source of epithelial ingrowth. So this is one more complication.
Can you please sum up?
Yeah. So there was corneal scar with vascularization at the standard incision site. So the incision site was shifted from 90 degree to 150 degree. And all the maneuvering was done through the new incision site. So these are some other complications, which I'll just go fast. So the take-home messages. SMILE requires greater technical skill and has a steep learning curve compared to PRK and LASIK. An in-depth knowledge of various complications, prevention, and management of these complications are required for good visual outcomes. Thank you.
Thank you very much.
I think Dr. Payal is one of the only SMILE surgeons who has also undergone SMILE herself. So one line about how the patient feels during those 28 seconds.
Yeah, actually I was very nervous. I was tensed. And because I have seen suction losses before, means I underwent SMILE after observing this procedure for 28 days. I was very nervous that suction loss or something shouldn't happen so that my vision gets lost.
It will not lose. Nothing will happen. Even suction loss can be managed very well.
Even I got 6/9 vision on day 1, and after 1 month I got 6/6 vision.
Wonderful.
Good.
So
Wonderful.
let us go to the next presenter, the superstar from the Coimbatore, prolific phaco refractive surgeon, Dr. Anand Doddaramegowda. He'll be talking about his experience with the phakic IOL in low to moderate myopia. Over to Dr. Anand.
कौन सा shift ये बड़ा not this one low to moderate next not this presentation three low to moderate myopia not this one close कर दे बंद कर हिंदी में डाल
Can I ask one question?
thank you Kullu sir for the introduction. So I'll be speaking about Collamer usage in low to moderate myopia. So when we started doing our postgraduate days, we were all taught that ICL means it's restricted for the patients who are having very high refractive error. With the day progressed, we started doing it for -6 to -10. But now this is a new normal. Doing ICL, especially the Collamer ICL in low to moderate myopias. I'm just a high volume ICL surgeon. No financial disclosure. As soon as I say that ICL is for low to moderate myopia, there are so many questions among the refractive surgeons itself and from the other ophthalmic fraternity. Is it safe, reliable? What's so about cataract? What happens if IOP fluctuates? What is the explant rate? Who and all are doing it? What about endothelial loss? Because they are bothered about the cataractogenesis, glaucoma happening in a young patient. What sort of endothelial loss happens? And there are not so much studies published yet. In my experience, I think last 4 5 years I've done a good number of ICLs, and to be frank enough, I have not explanted any ICL out of the patient's eyes, and nor any patient developed glaucoma. Because of my high volume, I always considered a Collamer as first among equals, along with corneal-based refractive surgery. I offer ICL as a primary procedure whenever the patient's pupil size is bigger than 4.8. 4.8 to 5, because EVO plus lenses, the optic zone has been enlarged now. So this becomes a primary option. Physiological thin corneas, corneas between 480 to 440, they are not suitable for PRK or PRK plus. They are the ideal candidates. Patient asking for reversible procedure, and there are some patients in my huge volume asking for the same procedure just because they have their happy friends and families. Early keratoconus, non-progressive keratoconus, stable keratoconus patients, irrespective of their refractive error, I offer them. Patients suffering from moderate to severe dries, especially post-corona, digital abuse, yes, ICL is the option. And any evidence of keratoconus in their family, worried about ectasias, yes, ICL is my offer. I always advise them that ICL also a good option because contrast is never last. Professions requiring very good contrast, ICL remains the first option. It is devoid of all the complications which can happen with corneal-based refractive procedures. And to do this phakic IOL, Collamer is the only best material for, if at all, if you're choosing for low to moderate myopia. And the criteria as we know. And why this Collamer? Because this is one unique material, highly biocompatible material which can be used within the body. As soon as we say Collamer, it is biocompatible nature. It's a copolymer. It's hydrophilic in nature, almost more than 35% of water content. Because of it, it is very flexible. It is gentle, and the light transmission is almost more than 99%. See, the refractive index is around 1.4%. Rest of the materials, the refractive index is higher, almost goes more than 1.5. This is 1.45, nearer to the crystalline lens. What happens? The normal human eye secretes a material called as fibronectin. This fibronectin is attracted by the Collamer. This coats the Collamer. So the anterior chamber doesn't detect this as a foreign body. That's why we absolutely get a quite eye post surgery. Even a patient who might have suffered from idiopathic anterior-uveitis or traumatic uveitis, Collamer can be used. And one more thing we need to understand: 25 years down the line, ICL patients were explanting once they have become aged. We can see no deposits in the column. It looks so fresh. This happens because the negatively charged column repels all the negatively charged particles in the anterior chamber, unlike the other materials where you get the deposits of calcium all over the materials. The quality of vision, as I mentioned, is very very good because like 99% light transmission is there, and since the refractive index is nearer to the crystalline lens, internal aberrations are very much minimalized, and we are making incision of 2.8 to 3 maximum, so the product shape is maintained, the aberrations are not induced, contrast is never altered with this procedure. Long-term safety, even before the advent of central flow, the incidence of butterfly cataract was less than 1.3%, but with the advent of central flow technology, even this butterfly cataract chances are very much minimalized. Surgical time hardly takes 60 to 90 minutes. It's a peripheral incision, so endothelial cell loss is very, very negligible. And any topical phacosurgeon can perform this procedure. If you look into the recovery time, microkeratomes, yes, you do have all the symptoms of pain irritation for a day or so. With surface ablation goes until 3 to 4 days. Even with femtone smile, it ranges up to 8 hours. But ICL patients, the recovery is very, very fast. Since they enjoy very good Snellen's vision, contrast is not altered, patients remain happy. Even it's not extra added investment for the institutions also. Any phacosurgeon can do it. If at all, if the complications they are very minimal, if it happens, it's a reversible procedures, and the results are not dependent on the temperature and humidity of the room like eczema. Because of all these properties, Qualamar gives me confidence to go ahead and do in low to moderate myopias, and because of it, so many ICL implantations have happened. This is my small experience, minimum of minus 1.5. I've operated, and all the patients had AC depth more than 3. I have follow-up of 2 years. All the patients do maintain very good vision, 6/9 or better, and the spherical equivalent is around plus or minus 0.5. None of the patients are on anti-glaucoma medications, and they remain happy. Thank you.
Thank you very much. Thanks a lot. Please. So next speaker will be Dr. Coker. He will be talking on topo-guided treatment with MEL 90.
Yeah. Okay, so thank you very much, sir. So why did I start this topic? Because whenever you go, patient comes to you in the clinic, the first thing they say after your workup is, sir, can you do Contura for me? So then I went to the media and realized people are putting videos saying Contura is the latest. Can I have my videos? Can I have my slides, please? I'm not Sundaramurthy.
Yeah.
Yeah. I'm Sundar, but I'm not a Murthy. So it came to my mind, well, is something new? Then we went into the literature and realized it's not a new thing. And fortunately, at RP Center, we had both the machine. We had an EX500, which some people also called Contura machine. I don't know why, because it's just don't do Contura. It does all those things. Wavefront guided and optimized, everything can be done. So Contura is basically a topo guided refractive excimer procedure using EX500, which is Elcon product. So that's the only machine which does it. The answer is no, because if you see Carl Zeiss, they came with a model ML90, which was about 5 years back, and they had this system called Tosca, which had the topo guided, but somehow their machine or their guys could not manage to put it across to the people. So I've started again. I used MEL90, which has the same system. But if you had started that earlier, so all those people must be whispering in my ear, can you give me Tosca? So it's your fault. So you can still get back onto the bandwagon and make it. Because topo guided, I'll just tell you what it is exactly as compared to the wavefront optimized and guided. This is for the basic teaching. But and the other, if you have a Johnson machine, you can have iDesign, which works the same way, and the OBD Cat or Nidec. So if you have any of these machines, you can still do a topo guided without trying to switch over your machine just because you want to have a Contura. It's something like you're going to buy a toothpaste. You can have a Binaka, Colgate, or whatever suits you. And you can even have the Patanjali thing if the Indian Make in India comes in. It's one thing you're buying, so that doesn't mean the other things are not equally good or bad. So that's what is my talk all about. And I think the Carl Zeiss machine is good, no financial interest. The best thing is that if you cut a flap, femto flap, I cut 80 flaps for the last 3 years, which none of the machine can do it, which we tried on FS200 of Alcon. After 100 micron, it gives you the bubble breakout. So 90 micron, when you try, 10 to 20% patient might have a bubble breakout with a black, you have to abandon the surgery. And this one we're doing for the last 3 years. We've done about more than 500 eyes now without even a breakthrough with the 80 micron, and it's worked wonderfully well. But that's not what I'm talking about. I'm going to talk basically about what we are doing to ablate. So you raise the flap and you ablate the cornea. So when you ablate the cornea, you need excimer. So what is wavefront optimized? We all know that it does not correct the pre-existing higher order abrasions. So if it's there, it'll give you vision 6/6 again, but the abrasions, if they're there pre-op, will continue to progress. It'll stay like that. Whereas if you do a wavefront guided thing in which you can correct the pre-existing also. So it takes the pre-existing data, that means it takes the abrometry and puts them together and take it. When you do a topo guided, it basically take your refraction as well as the topo guided data which corrects. So it will actually take care of the abnormal corneas in much better way. So can we use it for the virgin corneas? The answer is, if you see the studies, you realize that there are lots of papers we're coming up for the last 3 years in which they use it in the virgin corneas also. And the RMS need not be very high to go for the topo guided. You can still get a good result in a virgin corneas also. So this is what the Contura was approved by FDA in 2016 for the virgin corneas also. Earlier, they used to all go for abnormal corneas in which there was a more RMS or there's a irregularity of the cornea. So similarly, there's one study with MEL 90 which was published again, in which they used this one for the virgin cornea. So with that in mind, we did a study at the RP Center. We did about 200 eyes on both the machines, and we realized that both the patients at the end of 6 months and 1 year were absolutely the same, no problems. So why should one machine be preferred? It's your choice to pick it up. There's some few shortcomings with the machines, both the machines. I'll just step on that and touch about that. So what we did, we take the data. The problem with the Contura, capturing of the data is very difficult. If you take 100 patients, maybe 55 to 60% of the patients, you can actually use the data which you can translate into the refractive surgery. Majority of them, you can't do it. Anybody has experience with the Algarato wavelight? Okay, so can you capture 100% patient? Never ever possible. I was in Australia, they were talking to me, why don't you switch over 100%? As if you can do it for my patient, I can do it. We put expanders, put all the funny things, looking up, looking down. You still can't get all the images because you're machine dependent. Whereas if you're putting yourself on the Atlas platform, the platform which we use for the Zeiss platform, you have a choice to actually go ahead and use your refraction also and mix and match, and you can get the result. So this is what the Atlas looks like. The basic thing, the 7th and 8th rings are the most important. The distance between the 8th and the ring are equal. So once you get this data which shows this one, you're good to go. You don't have to go any further than that. So I think this is a much superior and a better system to work on. So this is what it looks like, and the 4 images you can capture, and you can pick out the best. If all 4 are similar, which in 99 to 100%, if at the end of 1 week we could do. For the beginners, you might get 80 to 90%, which still is a very good yield as compared to any other machine which is available right now. So the non-acceptables, you can see gross ones. Of course, there's a dryness on the eye or the meibomian discharge. Of course, you're not going to do in this one. So blink the eye, put a refresh tear on the surface, come back again 10 minutes, and you can pick up the data. Okay, so topography and topo smooth is another thing we can add on, in which you can actually add on the map without refraction input and one with the refractive input. So once you think your data is not complete, it has little lags, you can actually add on the refraction to that, and your results actually matches. The final results are the same. Okay. So we did about 160 eyes with the EX500 and other with the MEL 90, and there was, of course, no contraindication surgery. All the pickup criteria were similar for both the things. I'm not going there. So what we realized that both eyes were equally good, and after 1 month and 6 months, this is the data. This is the pre-op pentacam of the patient. That's a 1 month and 6 months, and again pre-op 1 month and 6 months, and we realized that the hyoid abrasions, which also I think were much less in patients with MEL 90 as compared to the Contura. We're sending it for publication. Okay. Now this is one of the procedure on machine EX500, and this is what a wavefront optimized LASIK is. You go there, lift up the flap. So what I want to say, there's no difference in the delivery. It's just the mode of delivery of the examiner. Rest all procedures are the same. So just charging a little extra, 10,000 or 20,000 people are charging extra for just one step. I don't think that's justified. Anyway, it's their choice. Now, if you notice, all the ablation is right in the middle here, and it doesn't go to the periphery. Whereas when you're doing for a Contura, you need to have it actually fires little more. It covers bigger area, covers from the periphery. That's what the Contour is all about, and it comes in the center. So this is what is the basic difference. And if you do it on the machine, which I am talking about, MEL 90, and that's what it looks like. And this is an 80 micron flap. The only problem with the Zeiss machine is that when you're going on the topo mode, it gives you a frequency of half the frequency. So your time goes up. So this is a -6 diopter. Took me 24 seconds. So you have to talk to the patient. The good thing is that this machine has a pupillary capture, and it's eye registered. So if eye goes off the center, it'll stop firing. But still, there are chances that you can get some vertical comas if the eye moves upward. If that can be modified, I think your machine will be much better than any other. So that's the only drawback which we have. Otherwise, the results are absolutely fine. And we followed it for 1 year now, 6 months data I showed you. And this is what you see the firing going on. It's actually 21st-second firing, so I didn't edit it. So this is what it takes, and it takes time. Whereas the other machine is a little faster. Whereas the other wavefront customized modes are all 500 hertz. This one is the only which is firing at 250. I think if you guys can look into it, it'll be a big help for us. So coming at the final slide.
So the capturing is very good in MEL 90, whereas in the EX500 it's not as good. 4-scan, you can do it much faster. There you need more scans, and the chances of reproducibility is very low. No objective criteria to assess the quality of the scan here, whereas there the machine actually picks up, which is good thing and a bad thing both, because then you can't decide what you want to do. So no guideline to proceed for topo, which actually has to be written. We have to do more surgeries and come up with our own guidelines. Planning is much simpler. The only speed is low. Otherwise, the results at the end of the 1 year all my patients are absolutely the same, no problems. In fact, higher order aberrations were less in this group as compared to other. And thank you.
Thank you very much.
Thank you, sir. It was an excellent talk. I do agree with that. I do have got a MEL 80 system, the previous version. Still, it does a very good topo guided treatment. Only, yeah, it's very good. Only thing is that they are not marketed. Apart from that, is excellent. करने कैसे?
कर लो 5 मिनट का टाइम है
5 मिनट नहीं 10 मिनट होता है.
हाँ 10 मिनट दे देंगे.
No.
So I
discussion.
agree with you. This RISE platform is very good. I've been using the MEL 80 and 90 platform since 2012, and these topo color system CRS master works wonderfully. But the only problem is when the patient comes to OPD, they are saying, no, we want the contour, not a system like this. What do you say to those patients? How do you convince them?
That is the media thing now. You ask them what exactly is Contura, they won't know anything, because most of these people will not understand. Either they're too rich, they have too much money, they won't bother, or they're too poor, or they're applying for a job or something. And it's the media driven thing. So it's I think we'll have to get into that, because how can the media buy? So like if you want to buy something, there's so many ads coming, right? But you pick up the thing because you're wiser. So it's an ignorance for those people.
Agree, sir. But they want that this is not, you want the only Contura, not a thing like Contura. So that's where.
So what you can do is you can buy a second-hand machine which even doesn't work. You put a EX500, put it up there.
So that's what I've done, sir. I have two machines at my clinic. One is EX and one is the Zeiss MEL 90.
Exactly.
That is what I have done.
And you're using MEL 90. This one is for the show.
I'm using MEL 90.
No, I think that's right, because in Delhi also I've gone to 2-3 places. They are actually pulling their hair out saying that we have to buy it. So what they're doing is they're procuring the second-hand machines from somewhere and just parking it there.
Yep.
Because you can't afford, because RP Center we have enough money to burn, so we have both the machines running.
Yeah, even I am putting the topolizer to show them, because many of the times they come, they show me the picture. This is the Contura machine treatment planning, or show me that. So I'm just showing them topolizer, just lying there, just lying over
I'll
there.
tell you one thing, because the Contura guys who are operating, there were certain guys who got their wavefront, this thing capturing machine had gone bad for 2 years. It was out for repair.
I know.
And they were still doing Contura without capturing. So, well, that's it. It's all here.
And so regarding the smile, I think the most crucial thing which I have faced in my practice is you have to, iron the Bowman membrane for the wow factor for the next day. I don't know. I would like to have your
See,
input
my smile patients, even 500, the next day the 6.5 or 6.6, what are the vision? I don't have 6.9 visions. I don't know. That can happen only once. It's a new machine to a newer environment.
Exactly.
Each machine has to be fixed in that room with the humidity, the temperature, and what altitude from the ground you are. If you're at Mount Abu or you stay in Mumbai, it's going to make a difference. When we started doing smiles about 5 years back in RP Center, we had put the energy level at about 35, 36, and we were happy with getting cut. But when we realized the vision was 6.9, and gradually we reduced down to 27, 29, 28. Now we are good, and lenticules are perfect.
We are also on 28, and it's working very
exactly.
well.
27, 28 is the way to go, depending on what. So initially, I think even the guys who were coming to assist, they didn't know much about that. Gradually, we realized that. But now the wow factor is same. Correct. And the other things, all the interface-related problems, like how many people come across fibers going under the LASIK? Why? Because the AC duct or the what coat suits you wear. So the problem of that also is reduced minimally with smile, because that's one of my indication for people.
Also, do you watch the interface in the smile?
Never. I don't watch the interface at all. There's no need actually.
So then there are some remnants of the bubble which are left on the next day.
Doesn't make bubbles are healthy. They'll go away. The way they came, it's goes away.
You know that you get some.
If you have a foreign body, then there's a problem. If you have a foreign body, of course I'll go and pick it up.
Yeah.
And even washing the foreign body alone is not going to work, because it'll dislodge inside only. So you have to go hold it and pull it out.
All right, so we can
about the washing. Actually, we did a study between one eye washing and the other eye. We just left it like that. What sir did, absolutely not much difference. But if you want that wow factor, one single wash give you the wow factor. One single wash will give you the wow factor,
it won't make
because
a
of I've
difference.
been doing and training a lot of people. And also it give make little bit, of course, when you take out sometimes, if your any of your assistant give the dissector with some foreign body or some fiber inside or some debris, you can take it out. That's
Can you
what
get little hydration when you put a wash inside?
no,
I
no,
mean,
one
see, if you
single
want a
wash will
wow
be good.
factor, the only thing is a good docking without any black spots, a good cut with the optimal energy, and a good split without much fooling around. And I don't remove in the middle first. I go to the side. I go from side all the way across in one sweep. So whatever videos they showed, they're very good surgeons. But my way is different. There's so many ways you can skin the cat. So which is the right way depends on the cat which you're handling. If it's a tomcat, it'll scratch you back. So don't foot around in the center, because that's the optical zone. So I go to the side with, I don't use a flat one. I use the one with a thin, longer one, and I go all the way across one, and the second one I go inside and again all the way across. And I think it works wonderfully well.
Yes,
Yeah.
you're
Perfect.
right.
So at the end of the day, I think I'll prefer that machine because it gives me 80 microns. I'm doing all my 80 microns, and 80 microns, how is this helping me now? Because my anterior cornea is the strongest cornea. So if I can save, so all my patients which are actually going for ICLs because they're -7 or -8, and we have cornea say about a 520 also. So with 80 micron, my PTA is coming less than 40. So because that those 20, 40 microns, if they bring the patient from the intraocular surgery to the extraocular surgery, why not?
So Dr. Yogisha sir wanted me to talk my second talk. So this is what are the complications can happen during the smile. Already Dr. Payal has spoke, but just this is my financial disclosure. So first complication, I think probably what Dr. Sonu was consistently telling about the suction loss. What might be the real reason for suction loss? It might be machine related, as he said that long suction time, that is around 25 to 28 seconds, or mismatch between the contact lens and the patient wide to wide diameter. Sometimes it might be surgeon related due to the improper docking. So the other small causes for suction loss, if we can take about, one is like mechanical factors like tight speculum, improper application of the surgical drape. Coming to the anatomical factor, suction loss sometimes can happen with the patient with a very narrow palpebral fissure, deep socket, too dry or too wet cornea, or patient with a very poor fixation. So, and even it can happen in the anxious patients also, and patient who has got a nature of frequent blinking. So this small video about suction loss, there is some amount of already black spots happened. Then you could be able to see from the side already fluid is gushing in. Then suction loss happened. So how to manage it? Not to become panic. Immediately you can redock, then clear the contact lens, then machine will do the treatment in the same plane. So just to tell you that suction loss in the first, during the lenticle cut, you can convert into the femtolastic. In that moment you can finish up the cases. Femtolastic happen during the other procedure. So this can happen, not to become panic. I think me, Dr. Anand, been doing smile for a very long period. We never got any complication. 10 years. You can come out with a very simple dissection. Wherever it is adhering, you can go with the micro forceps, try to peel it away from the incision towards the 6 o'clock. You can take out very easily this lenticule. So there are other complications I'll be just showing you. One is cap tear and the side cut care. Somewhere if you plan for a very small incision site, sudden patient, if you move while doing the dissection, this can happen sometime with the bulky surgical instrument. I'll just show you one small complication with a cap cut. You could be able to see here there are already black spot happen. So during the lenticule cut, this is about the cap cut. So while doing the, because patient was also little uncooperative, so the primary dissection over, though he want to take out the lenticule, he could able to see how the cap has cut at the wound. So in such cases, not to become panic, actually, you can put the contact lens. Still, the patient will have a good vision later on. This is with the side cut. So you could able to see the treatment is done perfectly by the machine. 4 mm incision. Still, it was all my learning students video. I took it from the machine. So while taking out this with the micro forceps, when you're taking out this lenticule while doing the reverse, you could able to see there is a small side cut happen. Not to become panic, I think you can put the bandage contact lens and complete the procedure. So in conclusion, LASIK to SMILE, definitely transition is associated with some intraoperative complication. You have to prepare for that. Optimal laser sitting and proper surgical technique help to minimize the complication. Thank you, Anand.
Thank you very much. So, any questions from the audience? Thank you very much, everybody, all the speakers.